adverse effects of the corticosteroids. The second one is sudden withdrawal. Sudden withdrawal leads to the Addisonian's crisis or adrenal crisis. And if any person or patient take these corticosteroids for more than 2 weeks in the large dose, and when he stop the drug suddenly, so there is an Addisonian crisis. That's why tapering of the dose or gradual withdrawal is recommended. And what is the precautions during the long-term therapy? If the treatment extend over 2 weeks to month, the patient should be given supplementary therapy at the time of minor stress, as we discussed. Two false doses for 24 to 48 hours, and when there is a severe stress, up to 10 falls in the case of the accidental trauma or major surgery. And if the corticosteroid doses to be reduced, should be tapered slowly. And if the therapy is stopped, what happen? The hypothalamic pituitary adrenal axis may take 2 to 12 months for the function normally, and to maintain the normal cortisol level it will take 6 to 9 months. So that's why in that period we have to give the replacement therapy, and replacement therapy also gradually withdrawn. There is also suppression of the inflammation reactions. If the person take the corticosteroid for the long term, it will mask the infection, including tuberculosis and the viral infection. It will mask the peptic ulcer. So suppression of the inflammatory reactions, because patient didn't feel any inflammation. Inflammation is the sign of the infection. There is no inflammation, patient will not realize about the inflammation, and there is a masking of inflammation occurs, and these are occurs generally with the tuberculosis, viral infection, and the peptic ulcer. Teratogenic, contraindicated in the pregnant women, which may lead to the cleft palate. Other side effects include glaucoma and cataract. Cataract we discussed in the first lecture. Cataract, there is, and the we can say the image is not clear, vision is not clear, may leads to blindness. And the glaucoma, in the glaucoma there is a optical nerve is damaged, chances of the optical nerve damage, and increase in the intraocular pressure. Hypercoagulability, the blood time for the coagulation will be increased, and decrease the wound healing and the growth retardation. And these are the local effects: hypopigmentation, itching, skin atrophy, strie, and maybe produce joint destruction and septic arthritis. This is the same. When glucocorticoids are used for short period less than 2 weeks, it is unusual to see serious adverse effect. Less than 2 weeks, no problem. But if the dose is higher and more than 2, then there is adverse effect, including acute pancreatitis, inflammation of the pancreas. Drug interaction. If you will prescribe non-steroidal anti-inflammatory drug with the corticosteroid, it will increase the incidence of the peptic ulcer, and decrease its healing, because you know that the non-steroidal anti-inflammatory drugs are already causing the prostaglandins COX-1 and COX-2 inhibitor. And there is one adverse effect for the NSAID is the peptic ulcer. It will causes the gastric mucosa destruction. And we've seen that uh, corticosteroid itself masks the peptic ulcer by decreasing the prostaglandin synthesis. With insulin, it will antagonize the action of insulin, because we've seen that it causes the hyperglycemia. Utilization of the glucose by the body is decreased, and this all the glucose occurs in the blood. And with anticoagulant drug decrease their effect, because it causes the hypercoagulability, increase the coagulation time of the blood. And these are the contraindications where corticosteroids should not be given: presence of the infectious, especially viral infection. It will mask the viral infection. It will decrease the increase the healing time. Mental disorder, hypertension, and the heart failure, because it causes the hypernatremia. It will increase the hypertension. Diabetes mellitus. In diabetes mellitus, you can give only dexamethasone and betamethasone. And this dexamethasone and betamethasone is also called as fluorinated corticosteroid. Why it is called fluorinated? Because it contains fluoride group, Fl, fluoride, Fl, fluoride. That's why it is called fluorinated hydrocorticosteroids, dexamethasone and betamethasone, as they have anti-immunological effect and have no effect on carbohydrate metabolism. But if you give other steroid, they may create the diabetes mellitus or increase the hyperglycemia, except dexa and beta. Avoid in the patient of the peptic ulcer and the early pregnancy, because contraindicated, teratogenic. And which are the mineralocorticoids? Generally the natural one are the aldosterone and deoxycorticosterone acetates. These are the natural mineralocorticoids. And synthetic one is having the DOCA, deoxycorticosterone acetate, and the fluorocortisone. And generally in clinical practice, fluorocortisone is widely used, fluorocortisone. And natural one is aldosterone. Where it is used aldosterone, it is used in the treatment of the hyperaldosteronism. What is the hyperaldosteronism? The condition in which the aldosterone secretion is increased, and there causes the hypotension and hyperkalemia. These are the both main symptoms for the hyperaldosteronism: hypertension plus hyperkalemia, increase in the blood potassium level. So how it act? It act on its own specific receptor on the distal part of the distal convoluted tubule and collecting tubule, increase sodium reabsorption, which is called hypernatremia, and in exchange with the potassium, hypokalemia. So it will exchange the sodium and potassium. And what is the result? The hypokalemia, the potassium concentration in the blood will be decreased. So what first question, what happen in the hyperaldosteronism? It will increase the potassium concentration in the blood and hypertension. How can you treat? You need spironolactone. What is spironolactone? It is potassium sparing diuretic. It will save the potassium in the blood, in the blood. I will repeat again. Maybe I missed something. What is hyperaldosteronism? The condition in which, due to excess secretion of the aldosterone, increase in the blood pressure and hypokalemia, not hyper. I will correct it. Hypokalemia. The potassium concentration in the blood is decreased. So how can we treat? We need the drug which preserve the potassium, that is spironolactone. Spironolactone is a diuretic which preserve the potassium in the blood. And as a diuretic, we know that diuretic action causes the decrease in the blood pressure. It will decrease the blood volume and decrease the blood pressure. So spironolactone, triamterene, and amiloride, these are the treatment for the hyperaldosteronism. And the last one is the surgical removal. So this all about the corticosteroids.